All right, so we're picking up with regulatory issues in managed care, starting on page 127 in the text. I do have a throat lozenge in my mouth, so if you hear something, that's what it is. I'm still getting over being sick, so I'm going to power my way through this. Managed care is concerned with two types of regulatory organizations: governmental agencies and voluntary accrediting associations. Governmental regulations take place at the federal and state levels. Federal regulations is concerned with the care provided to enrollees of government programs, and state regulations is concerned with the managed care organization's insurance license. So we're going to drop down and talk about CMS. Medicare entered the managed care arena as a direct purchaser through the Balanced Budget Act of 1997 with the plan called Medicare Plus Choice, or Medicare Part C. The Medicare Modernization Act of 2003 increased payments to this program and renamed it Medicare Advantage. A beneficiary who enrolls in a Medicare Advantage plan is responsible for both the Medicare Part B premium, which is retained by the Medicare program, and any additional premium collected by the Medicare Advantage plan. Medicare Advantage plans may offer additional benefits such as prescription drugs, eye exams, hearing aids, and routine physical exams, but at a minimum must provide the coverage that Medicare would provide. Enrollment in the M plus C plans in 2002 was estimated at 5.6 million beneficiaries, or 11% of the Medicare population, but enrollment had started to decline. In 2004, after CMS implemented Medicare Advantage and increased payments to participating health plans, enrollment in the program began to rebound. In 2014, Medicare Advantage enrolled over 15.8 million beneficiaries, which is about 30% of the Medicare population. All right, moving on to CLIA. CLIA is the Clinical Laboratory Improvement Amendments of 1988, and it was originally developed in response to concerns about potentially preventable deaths caused by poor Pap smear testing. This law, which became effective on September 1st, 1992, refers to all laboratories, including those operated in HMOs and physician practices within managed care networks. The basic items that CLIA addresses are testing complexity, personnel standards, proficiency testing requirements, quality control standards, patient test management, cytology testing, inspections, and fees. The CLIA regulations require that every laboratory possess a certificate to operate, and that sanctions are imposed on a laboratory that fails to meet the operational standards or proficiency testing guidelines. And MCOs require proof of CLIA compliance during the laboratory contracting process. Let's talk about state regulation. Although many MCOs providing services to Medicare and Medicaid beneficiaries are regulated by CMS, many MCOs are not. MCOs with only commercial enrollees are regulated solely by their individual state insurance laws. These laws vary throughout the United States and are administered by the Insurance Commissioner's Office or HMO regulatory agency in each state to ensure that the MCO is financially able to operate as an insurance company. Now we've got our different voluntary accreditations. We have NCWA, and we have the Joint Commission, or Accreditation Association for Ambulatory Health Care, and then you have the choice of both. You can have both NCWA and Joint Commission, or AAHC. AAAHC. So let's talk a little bit about NCWA. NCWA was formed in 1979 by the managed care industry, and NCWA is the National Committee for Quality Assurance. The Washington, D.C. based organization originally did governmental reviews for federally qualified HMO status in the 1980s. In 1990, NCWA became an independent nonprofit organization, receiving a grant from the Robert Wood Johnson Foundation to develop a new set of standards separate from those of trade associations. In 2010, NCWA offered accreditation programs for health plan accreditation, wellness and health promotion, managed behavioral health care organizations, new health plans, and disease management. The NCWA Health Plan accredited standards include the following sections: quality management and improvement, utilization management, credentialing and recredentialing, members' rights and responsibilities, standards for member connections, and performance measures. Now let's drop down to Joint Commission. The Joint Commission, which was formerly known as JCAHO, or the Joint Commission on Accreditation of Healthcare Organizations, performs accreditation surveys for many types of facilities that are included in managed care networks, using the appropriate accreditation manual for each type of facility. So there's a different manual for hospitals, there's different manuals for ambulatory care, and there's different manuals for managed care. Now, the Accreditation Association for Ambulatory Health Care, or the AAAHC, accredits the healthcare delivery portion of staff model, group model, and network model HMOs. It uses the Accreditation Handbook for Ambulatory Healthcare to survey the physician office and clinic portions of these HMOs. The survey consists of an on-site visit by at least 2 surveyors for a minimum of 2 days and is aimed at the healthcare delivery aspect rather than the insurance aspect of the HMO or the MCO. And then we have URAC, formerly the Utilization Review Accreditation Commission. It began accrediting health plans and preferred provider organizations in 1996. URAC publishes both health plan and health network standards. On one hand, the Health Plan Accreditation Program provides a comprehensive review of health plan operations in 5 areas: network management, quality improvement, credentialing, and member protection and utilization management. The health plan standards are appropriate for HMOs and other integrated health plans. On the other hand, Health Network Accreditation does not include utilization management and is better suited for PPO accreditation. In your textbook on page 130, there's table 4-1. It's the Voluntary Accreditation Associations. You have your accreditation association, and then you have their applicability. So NCQA is all HMO, PPO, and POS plans. The AAAHC is your staff model HMOs, your group, but not staff model HMOs at each clinic site, but not as an HMO. Group model, HMOs at physician group, but not as an HMO. Network model, and HMOs at a clinic site, but not as an HMO. So know the Accreditation Association and what their applicability is, because you'll need to match this on your test for Chapter 4. All right, so we're going to move on to revenue generation at the bottom of page 130. The MCO produces its revenue by selling an insurance product, which enables it to provide quality health care to the member. In turn, the MCO must pay or reimburse the providers of care for the services they provide to the members on behalf of the MCO. Premium payments are received from multiple sources in the MCO. Employers pay the premiums for a large percentage of members, but some members pay their own premiums because of changes in employment or self-employment. Some MCOs also contract with the government to insure Medicare and Medicaid patients, and the MCO receives the premiums directly from CMS or the individual states on behalf of these members. So the amount of the premium payment can be determined in several ways, either by the community rating, which is a method to determine premiums that's based on actual or anticipated costs for members in a specific geographic location. The age or sex rating is a method of structuring premiums based on enrollee membership statistics of age and sex. And a composite rating is a method of determining premiums in which one uniform premium applies to all subscribers regardless of the number of claimed dependents. And the experience rating, it determines premiums based on actual utilization of individual subscriber groups. So be sure to know these as well, because this will also be matching on your test. All right, dropping down to reimbursement to the provider. So let's talk about salary first. In a staff model HMO, providers of care are actual employees of the HMO. Providers work under contract but receive a monthly or bi-monthly salary payment regardless of whether their patient panel is full. And a panel is a group of patients who have chosen a specific provider as their primary care provider, so PCP, primary care provider. The size of the panel is HMO specific, either by raw numbers of members, such as 1,600 members, or stratified by age group, such as 400 children, 1,000 adults, and 200 seniors. Then you have your capitation method. This is per member per month. Capitation is the payment of a fixed dollar amount for each covered person for providing a predetermined set of health services for a specific period of time. Flipping over to 132. Example of this is the provider may receive $40 per month for each patient assigned to him or her, whether or not the patient actually comes in and receives any care at all, or if the patient comes in 5 times in a month. This capitation payment usually is made monthly based on the monthly patient panel or assigned groups of patients. This rate is known as per member per month, or PMPM. Out of the capitation payment, providers must pay the support staff and office expenses. Claims are sent to the MCO for information purposes only and not for payment processing. Under this arrangement, providers who practice effectively can make money, whereas those who do not manage their resources well are financially at risk. So if your payment is $40 a month and you have 5,000 patients and 2,500 of those come in once a month, then you're getting paid for the 5,000 no matter what. So let's just put some raw numbers to this. 5,000 times 40. That's $200,000. So they're going to get paid $200,000 because they have 5,000 enrollees. But if 2,500 come in, they're only getting paid 40 for those, so they're only getting paid $100,000 to take care of those 2,500 patients. So if they can stay under $100,000, then they made money. Or even if they can stay under the $200,000, then they've made money. But if they have the 5,000 patients, that's $200,000 a month, but they have 5,300 visits in a month times, we're just going to say the 40, then, they're going to lose money because, again, if you get paid a certain amount per person, but that person has 5 visits in a month, you're still only getting paid $40 one time a month per member. So it's not $40 every time that member comes in. It's $40 one time per month. So remember, per member per month. All right, moving down to per diem. Per diem means paid by the day or at a daily rate. These rates are negotiated with centers such as hospitals and skilled nursing facilities. The per diem covers the nursing care plus room and board charges. Special procedures or surgical services are charged separately. This amount is the only payment the facility receives for the care. Then we have fee schedule negotiated. The MCO and the provider can negotiate a fee schedule for a flat rate per procedure, visit, or service. This allows any provider willing to negotiate to be a part of the MCO network, even those for which no historical data are available on use and cost. This method is normally used when services are needed less frequently, but the cost varies widely from case to case. Negotiating a fee schedule allows more consistent budgeting of payment dollars by the MCO. Then we have fee schedule on the resource-based relative value scale. So another way to negotiate a fee schedule is to use the resource-based relative value scale, the RBRVS, unit value as the base, and negotiate the conversion factor, the dollar amount per unit. That provides appropriate reimbursement. As an example, if the RBRVS unit value for a procedure is 2.5 and the negotiated conversion factor is 45 for all procedures, the fee paid to the provider in this case would be $112.50. So what they did was the 45 times 2.5, and that gets you $112.50. Then you have a fee schedule as a percentage of Medicare physician fee schedule. Some payers create their fee schedules based on a percentage of the Medicare fee schedule. Some do 135% of the Medicare fee schedule. So, for example, if Medicare allowable for a service is $85.60, the payer allowable would be $115.56, so 35% higher. Then you have your DRGs, your diagnostic related groups. DRGs form the basis of your inpatient prospective payment system used by Medicare, some other payers, and some managed care organizations to reimburse acute care facilities. This payment system is a prospective payment system, meaning that the rates are established before care is provided. Each patient's discharge is categorized into a DRG based on the principal and secondary diagnosis, including comorbidities and complications. Each DRG is assigned a payment weight based on the average resources to treat patients with that DRG. The goal of this payment system is to encourage facilities to manage their operations more efficiently by finding ways to deliver more cost-effective patient care without sacrificing the quality of care. And then our last is discounted charges. In the discounted charges method, the provider agrees to see MCO patients and charge the MCO the regular fee-for-service rate. The MCO discounts the rate by a certain amount, usually a percentage, before the payment is made. Negotiating this payment method is the easiest to accomplish, offers the greatest financial risk to the MCO, and gives little financial incentive to the provider to practice more cost-effectively. The total charge may be limited by a maximum allowable threshold for a given service. Depending on the type of provider and the contract with the MCO, the provider receives payment from the MCO by means of one or more of these reimbursement mechanisms. Except when copayments are required as a provision of the health plan contract, any remaining balance cannot be billed to the member. Those balances become the cost of doing business for the provider and cannot be billed to any other party. And if you want to look at the summarization of the advantages and disadvantages, you can flip over to table 4.2 on page 134. And it gives each one of these methods we just talked about in that section. So we've got salary, capitation, per diem, and so on. So we have advantage and disadvantages. So be familiar with this table. You're not necessarily going to have to match. But you might want to know those advantages and disadvantages of each one of those methods. All right, moving down to coordination of benefits, back on page 133. Coordination of benefits means determining the primary insurance payer and ensuring that no more than 100% of the charges are paid to the provider and/or reimbursed to the patient. Some patients have two insurers because both spouses receive coverage through their employer or because they have purchased an HMO policy to supplement the deficiencies of a basic policy such as Medicare. It is in the best interest of an MCO to determine and record the primary insurance carrier for each member so the coordination of benefits rules can be applied correctly. In some cases, the MCO may be the secondary payer. The method of determining the primary payer in dual coverage cases is different from state to state. The most popular method used in determining the primary payer when both spouses carry insurance for the family is the birthday rule. The spouse with the birthday earliest in the calendar year is the primary insurer for the children, with each spouse's insurance being primary for them. So, for example, if both me and my husband had insurance coverage, and we could both cover our kids, his birthday's in February while my birthday's in April, so he would be the primary coverer for our kids, not my insurance, but his. So that's the birthday rule. It's whoever has the earliest birthday in the year. It's not the oldest spouse, but it's the birthday that comes first in the calendar year, because I'm older than my husband, but his birthday's earlier in the year. So determining whose insurance is primary for the family is important to the MCO because for dual covered family, the MCO may be the primary carrier for the subscriber only and not for the other family members. If the subscriber's spouse carries the primary insurance for the family, the MCO is responsible for the full level of benefit for the subscriber and only the unpaid balance, usually 20% or less, on the other family members. HMOs must follow the rules for determining when Medicare is the secondary payer. The MCO that owns healthcare facilities can bill other primary payers for that care provided in its facilities or by its salaried or capitated providers, thus offsetting the expense of care. When paying claims, the MCO can direct claims to other payers if it is not the primary payer. And then we got workers' comp, motor vehicle accidents, and personal injury cases. Top of 135 here. If an MCO member is injured at work in a motor vehicle accident or by another individual, the member may prefer to receive care from the PCP. Remember, we talked about PCP being your primary care physician or primary care provider. Actually, it may be better for the patient's overall health and wellness to see the PCP, who knows his or her medical history. In these situations, the MCO can submit a claim to workers' compensation, motor vehicle, or other personal injury carrier and receive reimbursement for the care provided. This diverts the expense to the appropriate insurance carrier while the MCO's overhead and or capitation remains the same. All right, so we're going to cut out here, and we'll pick up in our third lecture series on information management, and we'll finish out the chapter there. Thanks.